2020 is, strictly speaking, the third year of the Radiopedia review course. And each time I find myself planning the next year's content as soon as the previous course is finished. So I have been looking forward to talking to you about ovarian masses for a very long time. And I'm going to be specifically focusing on ultrasound of ovarian masses. And that is not out of contempt for other modalities. Ultrasound is an excellent tool for problem solving at adnexal lesions, and CT, of course, is essential for staging. However, ultrasound is still the primary modality in assessment of adnexal pathology and is an excellent triage tool in tumour analysis. But this is only true if it is reported in a clear and consistent way. And so we're going to be discussing today how to describe ovarian masses in a standardized manner, how to convey risk so that the report is useful in guiding the referrer. And to this end, we're going to go through several of the recent risk stratification systems. And we're going to talk a little bit about recommendations for management for best patient outcomes. So I'm going to start off by being critical. But luckily, I'm not critical of anyone in particular, but of this fictitious report conclusion, which admittedly vaguely represents some of the reports that I have seen and probably written in the past. I'm going to take particular aim at the term complex cyst and suggest that you try to either reduce or eradicate the use of this term from your reporting vocabulary when describing adnexal masses. At the very least, don't use it as an isolated descriptor because it doesn't mean anything. My imaginary colleague goes on to say that the nature of the lesion is uncertain and recommend referral to a gynecologist. Now, that may be the right thing to do in some cases. However, if this is in fact a physiologic lesion, such as a hemorrhagic cyst, he may save the patient a lot of stress and money by recommending ultrasound follow-up instead. Alternatively, if the lesion looks like a cystic neoplasm, then he should be suggesting that they see a gynecologic oncologist, because surgical outcomes for malignant tumours have been shown to be significantly better in a patient operated by a gynae-onc specialist rather than a general gynecologist. And these images really just bring home the point about complex cysts. So both of these lesions may be called a complex cyst, but the one on the left has the typical appearance of a hemorrhagic cyst and will resolve, whereas the one on the right is also a complex cystic lesion in that sense, but is very concerning for a neoplasm. So I'm going to introduce you to 3 ovarian tumour at risk stratification systems. And if you're already thinking, do I really need to know all 3? Well, you don't. You may sway towards one or the other depending on where you live or what is local accepted practice, but I do think it is helpful to understand all 3. So IOTA Simple Rules was the first stratification system that was developed by the European-based IOTA group and is almost a binary system where tumours are designated as either benign or malignant, and if they don't fall into either categories, then they're deemed inconclusive. The adnex model is a mathematical model that was developed by the same group as the IOTA Simple Rules and based on the same data sets. But as you can see, it is a scale which gives a percentage risk. And ORADS is essentially the American cousin of adnex and IOTA. It was developed in conjunction with the IOTA team and it was based also on the IOTA data sets, but has adopted the familiar RAD structures such as BIRADS and TIRADS, where the risk of malignancy is subdivided into categories from 1 to 5, with 1 being normal and 5 being a high risk of malignancy. And I should preface from the outset that I have in no way any affiliation with any of these stratification systems, either clinically or financially. My only bias is the promotion of value adding in our radiology reports. So here's the outline of the IOTA Simple Rules. And you can see, as we mentioned previously, that there is a series of benign characteristics labelled from B1 to B5, and they are a unilocular tumour, a tumour with solid components, all of which are less than 7 millimeters in size, the presence of acoustic shadows, a smooth multilocular tumour that is less than 10 centimetres in size, and a tumour with no blood flow, colour score 1, and I will go through the colour scoring system a little bit later on. Whereas the 5 M features or malignant features are an irregular solid tumour, presence of ascites, presence of at least 4 papillary structures, an irregular multilocular solid tumour if it is more than 10 centimetres, and very strong blood flow or colour score 4. And if the lesion has at least one B feature, it doesn't matter how many, whether it's one or more than one, but if it has B features and no M features, then the tumour can be classified as likely benign. And conversely, if it has any number of M features and no B features, then it can be categorized as most likely malignant. A tumour that has neither B or M features, or it has combination of B and M features, is inconclusive, and the iota simple rules cannot be applied, and further characterizations such as specialist review or other modality imaging is necessary. And I should just point out that this image may be a very familiar picture for those who are familiar with iota simple rules. And this slide is of course based on and references the iota group, and even the colour scheme references the iota group, but just to take note that it's not exactly the same images because the specific cases are all out of the Radiopedia case library and they're referenced with the case ID numbers. So prior to releasing the iota simple rules, the iota group had come up with a set of terms and definitions which comprise the iota lexicon, and I'm just going to spend a little bit of time just highlighting a few key points out of that lexicon. And in particular, this is probably the slide that addresses my gripe with the term of the complex cyst. So rather than saying that it's a complex cyst, one of these terms can really be applied. So a cyst may be unilocular or multilocular, so you can make that decision from the outset. Is it a unilocular or multilocular cyst? And are there solid components or are there not solid components? So it may be unilocular cystic, unilocular solid, if there are any solid components, multilocular cystic or multilocular solid, or alternatively a solid lesion. And you may have a predominantly solid lesion with some cystic components, and the arbitrary cutoff is if it's approximately 80% solid, then we regard that as a solid lesion. Another component out of the iota lexicon is the term of the papillary projection, which we use quite a lot. And I must confess that when I first started reporting gynecological imaging, I was confused by this word because when does a nubbin on the cyst wall become a papillary projection, and when is it no longer a papillary projection, but is it now a solid component? And so it was quite useful to have this set of definitions where papillary projection is actually a subtype of a solid component. So if you have papillary projections, it is a cyst with solid components. It arises from a wall or a septation, and it protrudes into the cyst lumen with an arbitrary height cutoff of 3 millimeters. So if it measures more than 3 millimeters, it can be called a papillary projection. In order perhaps not to insult our collective intelligence, the iota group have conceded that we may not always need to go through the full checklist of the simple rules, and that there are some benign lesions that are so typical that they may be diagnosed confidently from the outset. And so they have nonetheless provided us with a set of standard descriptive terms that would help identify these lesions. So unilocular cysts with regular walls, which are generally simple cysts or cyst adenomas, unilocular cyst with mixed echogenicity and acoustic shadows in a premenopausal patient. So in other words, a typical appearance for a mature cystic teratoma, dermoid cyst, or a unilocular ground glass echogenicity in a premenopausal woman. So in other words, features consistent with endometrioma. If any of these are present, it's sort of a gestalt diagnostic appearance. You don't need to go through the definitions of the simple rules. And likewise, they have offered some malignant easy descriptors. So in a patient who's got an ovarian mass with at least moderate vascularity and ascites, and it is a postmenopausal patient, this is sufficient to regard this as a malignant lesion despite any other presence of any other features. And also in a patient aged more than 50 years old with a CA125 of more than 100, with no other factors of what the lesion might look like, this is sufficient to be suspicious of malignancy. And so just take note that this is the first time in all of these descriptors that CA125 has actually come into play, and we'll talk about that a little bit more further. I mentioned before the presence of an iota colour score. It is a very simple system where colour score 1 means no vascularity, colour score 2 is minimal, 3 moderate, and 4 is marked. So it's very subjective, but most of the time, certainly colour score 1 and 4 can be quite well differentiated. And it's actually quite easy to apply. So moving on to the iota adnex model, which, as we mentioned, is a mathematical sort of model which is derived from the same data set as the iota simple rules, but takes a somewhat different approach. Here we've got 3 clinical factors. So patient age, whether or not they're referred or they're being examined at an oncology centre. And the third at the bottom is the CA125, but this one is optional. So you can complete this and calculate this without the CA125. And then there are 6 lesion characteristic factors. So maximal diameter of the lesion, diameter of the largest solid component. Are there or are there not more than 10 locules? So 10 locules being a cutoff. How many papillary projections? And there will be a choice of none, 1, 2, 3, or 4 plus. Are there acoustic shadows present, and is ascites present? And so you can find this very easily if you Google iota adnex model. It should lead you to the correct page where this calculator is based on the iota website. It is free, and there's also an app for adnex model, which, as far as I know, has a cost. So go to the website. So ORADs developed, as we said, in conjunction between the iota group and some key governing bodies within the North American radiology system. So this is an article that was printed in the Radiology Journal of the Ultrasound Risk Stratification and Management System. And this is the key table which outlines the risk categories, the lesion descriptors, and suggested management. And we haven't seen suggested management given before. And this is one of the key ways in which the ORAD system is different to the other ones. So it offers suggestions for patient management. Now, with me putting this slide on here, you may think that I have put on text which is too small to read, and that I should be apologizing that there is text that's too small to read. And yes, I have put on text that's small to read, but I'm not going to apologize for it, because I'm not putting it there for you to read, but rather to see what it looks like so that you can now Google it. I'm making use of the fact that this is a straight to DVD video. So please Google ORADS ACR, and I think that should be sufficient. And I would suggest having this alongside the talk for when we get to the tumor analysis and case analysis part of the talk. And feel free to pause, of course, as you do that. And just to mention, of course, that this system is excellently summarized on the Radiopedia website as well. Risk assessment models that I've been talking to you about have been the subject of a vast amount of research, both internally within the IOTA group, but also through external validation. And this is something that I wanted to point out from one of the large analyses which assessed the ADNEX model and compared it to other frequently used ultrasound methods. And so this study and other studies have shown that the ADNEX model and simple rules in conjunction with clinical assessment are superior in their sensitivity and specificity to many other previously commonly used ultrasound methods, such as RMI, which was a popular tool in some areas for assessing risk of adnexal pathology. But of particular interest to me was this phrase in the conclusion that although the test performance of subjective assessment by an expert remains superior, the ADNEX model can help with differentiation between benign and malignant. So the subjective assessment by an expert remains superior. And this is an interesting point where, whilst we're talking a lot about how these systems might help us in the diagnosis, it's nice to hear that perhaps what we also need to be doing is just knowing our stuff. So what I'm hoping in the remainder of this talk, we will address the various risk stratification systems, but we're also just going to hone in a little bit on knowing our stuff about adnexal pathology. And I'm even going to be bold enough to take on the IOTA simple rules and offer my own keep it simple rules of thumb that sort of address the factors that we've described before, but really just bring it back to what you might be thinking about in your objective assessment of a lesion. And here they are. So firstly, big is bad, and this being rules of thumb, this is not always the case. So some big tumours are in fact benign. So for example, cystadenomas, and particularly mucinous cystadenomas, can get very big slowly before they're diagnosed. But in general, when the larger the tumours are, really the more suspicious they become. Secondly, solid is bad. Again, not in all cases. There are exceptions. The typical fibromas, for example, are benign, but in most cases, solid tumours are either malignant or you can't tell, and then you need to take them out anyway to get the histological diagnosis. Vascular tumour is bad, and the presence of ascites is bad. That holds fairly strongly true. And for a bit of good news, shadows are good. And as radiologists, of course, we're glad to hear that shadows are good. So what lesions tend to shadow? Well, it's predominantly either the dense fibrous ones, such as fibromas, or the echogenic components of dermoid tumours. So that's a large component of shadowing lesions. Shadowing calcifications is a little bit of a different categories, because calcifications are not talked very much about in this analysis, and they can occur in a variety of settings. But by and by, if you've got lesion with shadows, this is a good sign. And a few extra points. So these are the less definitive ones, perhaps to an extent. Septations are not necessarily bad, but are not physiological. So if you've got a lesion with thin avascular septations and no other features, this is not an indicator of malignancy. So for example, cystadenomas and especially mucinous ones will often be septated. Other lesions such as dermoid cysts can have septations. So although you may see septations in malignant tumours as well, they will not be the feature that will make you concerned, except if they are thick, very vascular type of septations. So septations are not necessarily bad, but not physiological. You won't, for example, see a follicular cyst or follicle with septations. Papillary projections can be bad, but are not terrible. And the reason I say that is papillary projections most typically are a feature of borderline tumours, and borderline are thought as tumours of low malignant potential. So whilst they need to come out, their prognosis is quite good. You can get papillary projections in more malignant tumours as well, and there's certainly overlap, and we'll look at that as we go through cases. But if you've got a lesion which has no concerning features other than the presence of papillary projections, you can be perhaps cautiously optimistic that it might be a borderline. And tumour markers have a limited role in stratification. So coming back to the stratification systems that we've seen, note that only the ADNEX model actually includes CA125, and when I'm talking about tumour markers, really here we're talking about CA125. Only the ADNEX model includes CA125, and even there it is seen as an optional feature. And so the IOTA group research has found that CA125 doesn't in fact contribute to differentiation between malignant and benign tumours, but it can help separate high-grade tumours from either borderline or low-grade tumours or from metastases. And this is particularly true in premenopausal patients where the rate of false positives is high when CA125 is considered as a marker of malignancy at first diagnosis, due to, firstly, benign lesions that can cause, so false positive rate is high due to benign lesions that can cause elevation of CA125, such as endometriomas and abscesses, and also increased rate of false negatives due to increased prevalence of borderline tumours and other rarer tumour types that do not cause a rise in CA125. So as we move towards the case review part of this talk, we will briefly revisit the main histological tumour types. Note that these are not complete lists, but just to remind you that the main tumour histological groups are the surface epithelial tumours, the germ cell tumours, and the sex-cord stromal tumours. There's sort of a mixed bag of metastases, lymphoma, and other mixed tumour types, which are very rare. So surface epithelial tumours, serous and mucinous. Serous particularly is the most common, followed by mucinous. Both serous and mucinous have 3 subtypes. So the cystadenoma, the borderline, and the cystadenocarcinoma. So just a little reminder. So serous and mucinous. In general, mucinous tumours tend to be more septated. A serous cystadenoma will have either no septations or few septations, and typically, classically, a mucinous cystadenoma will have a few more septations, so thought to be somewhere between 2 and 10. And will also have potentially low-level echoes within it because of the mucin content of the tumour. As we move towards borderline tumours, what we see is the appearance of papillary projections, particularly within the serous types, but really within both. And in mucinous tumours especially, we note the increase in the number of septations. So if you see a tumour with lots and lots of septations, specifically more than 10, then you're hedging more towards borderline, knowing that there are, of course, overlaps between all these categories. And cystadenocarcinomas, of course, are much more complex with solid components and thicker and irregular septations, and potentially extension of tumour nodules outside the wall, so wall becoming more irregular. Other types to mention quickly is the clear cell and endometrioid. Just to remember, both of these are associated with endometriosis. And so if you see a tumour appearing within the setting of endometriosis, it is quite rare, but those are the common tumour types there. Endometrioid cancer also has a high association with endometrial, so cancer of the endometrium. So it's good practice whenever you're assessing an ovarian lesion to just review the endometrium as well and make sure there isn't a endometrial thickening or a mass. Brenner tumor is sort of something of a good guy that got mixed up with the wrong crowd. They're predominantly benign. They don't look like the rest, so they're typically a small solid tumor, but histologically they're surface epithelial tumor. Again, very rare. So, on to cases now. First case, incidental finding on ultrasound of an incisional hernia, so an incidental finding in an 80-year-old female. So we're going to just review this case first. So we see what is an anechoic lesion. So there are some septations, and we don't see any solid components. So this is a multilocular cystic mass in the adnexa. It's got a couple of smaller locules and one larger one. Just looking for an overall measurement in there somewhere, so measuring just under 5 centimeters. And so there's nothing else to it. So 80-year-old female, obviously it's not normal for an 80-year-old female to have a cystic 5 centimeter cystic lesion in her adnexa. However, there is nothing that's outwardly concerning about this. There's no solid components, there's no vascularity. The appearance overall is quite reassuring, so I would say that this is likely to be a benign lesion. So it's benign, such as a cystadenoma. So, and if we look at what our stratification systems say about this, so according to the IOTA simple rules, and at this stage, please do, I would encourage you to bring up the IOTA simple rules and the ORAD system and ADNEX model alongside. And so feel free to pause as you go along and trial out whatever systems interest you alongside these cases or through these cases. So in this case, IOTA simple rules, 1B feature because it's a smooth multilocular tumour. ADNEX model, you can punch in the numbers, I haven't shown you there, but it says 96% benign, and ORADS gives it a category 3, low risk of malignancy, 1 to 10%. So everyone's in concordance, and this case, I don't have clinical data for. She was followed up. It wasn't excised, but it was thought to be likely cystadenoma. Next case, 20-year-old female. So we do have a CA125 provided here. It's 44. Presenting with pelvic pain and fullness. Going through the pictures here. So obviously it's a multilocular tumour and clearly there are more than 10 loculations. So it's a multilocular tumour with lots of loculations. We're not seeing any definite solid components, so we're going to call it multilocular cystic. There's a little bit of vascularity, so here and there, so we'd give it maybe a IOTA colour score 2, and everything else looks normal. So thoughts on this one? I've just gone through the various appearances of cystadenomas, and to me this appearance is very much in that borderline kind of category. So there's septations, lots of septations, but nothing else. So if we look at the IOTA simple rules, we're in that inconclusive category. None of the B features and none of the M features apply to this. ADNEX. So here's the sort of results table that I haven't shown before. This is the sort of results table that the ADNEX model gives you. So here we've got age of the patient, 22. We'll say this was not in this was not in an oncology center, and we'll say that for most cases because we're just going to treat these as first presentation cases, first presentation to you in the community setting. This lesion measured 23 centimeters. There were no solid components. Yes, more than 10 locules, no papillary projections, no acoustic shadows, no ascites. And we, in this case, because we're given a CA124, we've entered it, but it hasn't really made any significant difference. I've tried it out both ways. And so according to this, we've got a 89% chance of benign tumour. And note that the ADNEX model not only gives you a risk of malignant versus benign, but it also gives you a breakdown of what the components might be. So if it was malignant, it's likely to be a borderline or low grade, rather than, so it's not considered to have any significant risk of actually being a high grade tumour. So 89% benign, and ORAD's category 4, intermediate risk for malignancy. So interestingly, these systems don't always correspond, and this is a good example of that. This is a lesion on basis of ADNEX model has got high chance of being benign. Reality is anything from 10% risk of malignancy onwards, they would still operate. And of course, on clinical judgment and clinical acumen, based on the size of the lesion alone, regardless of the ADNEX model, this would require surgery. And this was, in fact, a mucinous borderline tumour, as we suspected. Next patient, history withheld. There's something here I'm not telling you. 75-year-old. So we have a multilocular tumour with a solid component and internal vascularity. So it's a multilocular solid. Somewhere here we've got the size of it, 5.7 centimetres. Vascularity score, so sort of moderate. So maybe we'll give it 2 or 3. A few septations have got colour in them. There's no shadowing. And this is a separate finding. So this is in the pouch of Douglas. We've actually got a separate nodule in the pouch of Douglas, which has got internal vascularity in it. So this is something that is not in any of stratification systems that you'll see, but we see that, and our level of concern is immediately elevated even more. Because there's a suspicion for a peritoneal metastasis in the pouch of Douglas. So, interestingly, by the iota simple rules, we have no B or M features. Whereas by the ADNEX model, 75-year-old patient, 57 millimeter tumour with a 3 centimeter solid component, no ascites, no acoustic shadowing, even without taking into account the solid component that we saw. This is very likely malignant. And if you look at the breakdown, we're concerned particularly about a high-grade primary rather than a borderline or low-grade. And by ORADs, this is a multilocular tumour with solid component, colour score 3 to 4. It's category 5, more than 50% risk. And note that here, so again, the ORADs model gives you indications of management, so management by gynae oncologist, of course, for a category 5 lesion. So why do we have this discrepancy, or do we have a discrepancy? ORADs and ADNEX model are highly suspicious, but iota simple rules hasn't given us a malignant diagnosis. 2 points. Firstly, inconclusive lesions fall into that category where other assessment is required. So, of course, there's other clinical features and imaging features that will be taken into consideration. So, invariably, the diagnosis will be a malignant lesion for this. But the other point is, and I've withheld part of the history, once you had elevated CA125. And if you remember our malignant easy descriptors, a patient over 50 with an elevated CA125, regardless of the appearance of the lesion, is considered to be malignant. So even by the initial IOTA system, this still falls into a malignant category. And the other part of history that I withheld, which sort of was probably not helpful at all, is that this patient actually initially presented with a breast lesion, which was biopsied and thought to be of ovarian origin. So it was a ovarian metastasis to breast was the initial presentation. And so this was a high-grade serous cystadenocarcinoma. All right, moving on from, so all of those were examples of epithelial type cancers. So we're going to move on to our germ cell tumours. Range of tumours, they're overall approximately 20% of the spread between the different histological types, predominantly happen in younger patients. Okay, age withheld, clinical information not provided, but nonetheless, this is a very typical example of a lesion which is, so it's multilocular solid, because here we've got septation and here we've got a solid component, but immediately we see this echogenic area with acoustic shadowing. There's some we can see vascularity externally, but none within the tumour. And coming through, this is a beautiful, beautiful example, a very clear-cut picture. This is probably my favourite case of the tumour type. This is obviously a dermoid tumour. And our stratification systems agree that in this sort of case, we don't need to be applying IOTA systems or so on. We've got a benign descriptor. It is a unilocular tumour with mixed echogenicity and acoustic shadows, and we can diagnose it fairly confidently. But just to make the point that, as I said, that was an excellent example of a very beautifully presented dermoid cyst, and that is not always the case. So sometimes it's really hard to work out what's going on. That's just the reality of things. So if you look at the ultrasound images on this case, I'm looking at something cystic here. I think it's the bladder over here, but it's very hard to see. Is this part of a tumour that is shadowing, or is this bowel adjacent to some fluid? So far more difficult to be definitive on something like this. So just because this is a dermoid cyst, and I'm giving away the fact that it is a dermoid cyst, but just because it is a dermoid cyst doesn't mean that you'll always have that clear-cut spot diagnosis. So there are cases where you can sort of step away from any system and realistically say, look, this case, it's just too hard to assess with confidence. We need to do something else. And in cases like this, often we do go to MRI, and of course, although this is predominantly an ultrasound-based talk, this is MRI of the same lesion, and straight away, everything is so much more straightforward. So we see there's obviously a definite mass, and it's lying, here's our bladder. There's the uterus all squashed up here, and this mass is sitting right behind the uterus, and it's got various different components. It's got this T2 hyperintense homogeneous component here. It's got another component which looks T2 hyperintense, but not quite the same. It looks a bit dirty. Maybe there's a few really thin septations in it, and there's some other tissue around it. Looking at the same picture in axial planes, that's our sort of homogeneous component, and the somewhat dirty septated bit next to it. As we scroll through, we see a few follicles around this, so this confirms to us that this is of ovarian location. And on the T1, Our homogeneous component is of low signals, confirms this is simple fluid, and we've got T1 bright component here. And of course, whenever we see T1 areas in a lesion, in an adnexal lesion on MRI, one way or another, it's got to be a home run. You can work it out. And in this case, it's fat saturating. So this is a clear fat component in a dermoid cyst. Moving right along. Next case, a young patient, 12-year-old, acute pelvic pain. So 8 centimeters by 6.8, large multilocular lesion with solid components. So multilocular solid. With some of these components, it was somewhat debatable, difficult to decide whether this is really a papillary projection or is this something that's floating within the cyst. It doesn't have any internal vascularity. It's got sort of sharp margins around it, at least on this view. But some of them certainly do seem quite well placed on the septa. So these, even though they're vascular, these are certainly solid components. So multilocular solid tumour without much internal vascularity in a 12-year-old girl. So this is really hard. I mean, you know, there's no way we can tell what it is. And it makes it harder, of course. The risk proportions are different in a child compared to an adult. But, you know, the sense is that it's going to need to come out. And, of course, in a pediatric population, germ cell tumours are more common and they can have very variable appearances. When we apply our system, so according to IOTA's simple rules, IOTA is sort of a bit clueless, just like we are about this. So it says it's inconclusive. The adnex model, so it was a 12-year-old patient, but the adnex model doesn't go down to 12. So I've put in 14, and 14-year-old will have really the same risks as a 12-year-old. So 9 centimeter lesion with a maximal one of those papillary projections measured 2.5 centimeters. Yes, more than 10 locules. There's lots of small loculations around there. 3 papillary projections, no acoustic shadows and no ascites. So what we get is we've got reasonably high risk of malignancy, right? And most of it is thought to be considered as borderline risk, but 55% overall risk of malignancy. And according to ORADS, it's an intermediate risk for malignancy, which also recommends essentially a management by a gynaecologist. And so this is a struma ovari, which is a fairly rare subtype of the teratoma tumours, which has got a large component, predominant component of thyroid tissue. Just as a little bit of a side point, or perhaps for geek points or for path exam, maybe, really just out of interest. Whilst it's hard to be definitive about the diagnosis in a tumour like this, there is some literature that's described, and I've got a reference down below, and it's a very good set of papers of a specific appearance in struma ovari tumours named struma pearls, which are well circumscribed roundish areas of solid tissue which do represent thyroid tissue. And just in retrospect, I think there's a couple of areas in there that might just come under that category of struma pearls. Another case of a young patient, 14-year-old, presenting with abdominal distension, and we've got some tumour markers there. So she's actually got an elevated CA125 and a mildly elevated beta-HCG. Solid tumour, large, okay, 16.5 centimetres in diameter in the midline. And just coming back to that color picture. So very vascular, lobulated, irregular solid tumor. This is concerning regardless of age or anything else. But in fact, this patient had a CT scan as well. And we see that firstly, we've got the very large tumor occupying a large part of the central abdomen arising from the adnexa. But also she's got some paraaortic lymphadenopathy. So having the benefit of multimodality imaging, it even further, of course, increases our suspicion that this is a malignant tumor. And aorta, simple rules, it's got 2 M features. It's an irregular solid tumor, and it's got very strong blood flow. It's got no B features, so aorta is also worried. Adnex model, so with the lesion details of this tumor, adnex is very worried. It gives it a 52% risk of malignancy, and it's erring towards the even more of the higher grade tumors. And ORADS is also very worried, category 5. So this is a dysgerminoma, which is a malignant tumor. So we're all, I think, both our general opinion and all the stratification models were in agreement that this is concerning. And the only, again, extra point just for interest or, did I say geek points or something, is when you actually look at the stromal appearance of this lesion, take note of these echogenic bands that extend between what appears to be separate lobulations. So it's got a lobulated contour, and it's also got an internal lobulated appearance. It almost looks like a cirrhotic liver. And this is what the tumors look like histologically as well. So they've got these multiple lobulations with bands of tissue between them. So that's actually, whilst not enough to state the diagnosis confidently on imaging alone, but it's something perhaps to look for in tumors in younger patients. It's a appearance that's been associated specifically with dysgerminomas. Okay, and moving on from germ cells tumors to 6 called stromal tumors. So there are more types than these, but these are perhaps the main ones: fibroma, thicoma, granulosa, and Sertoli-Leydig. Fibromas are the most common, and pure fibromas are not hormonally active, but often you'll have combinations of fibrothecomas as well. Thicoma and granulosa tumors both secrete estrogen. And therefore they will be associated potentially with endometrial thickening. So another reminder, we talked about that with the endometrioid, but another reminder with thicoma and granulosa cell tumours, that they can be associated with endometrial abnormalities. And to put the backwards spin on that is, if in an exam setting you're given a case which has got a mass and endometrial thickening, and you're asked for a differential, you would then say that in the setting of endometrial thickening, some of the tumours that may be associated are the endometrioid, thicoma, and granulosa cell tumours. Sertoli component of Sertoli-Leydig are also estrogen producing, but just very, very rare. And the Leydig tumours so Leydig cells are the androgen producing. So just again to keep in mind in a patient presenting with virilization type presentation. Okay, so before we start diagnosing this area, please note that this is actually uterus, so we're still looking at uterus pictures, but we've got a mass with calcification and acoustic shadowing, and then we've got another one here. So we're actually starting off by looking at a multifibroid uterus. There's another appearance, and there's another fibroid which is echogenic. So coming through, right ovary looking normal, and in the left ovary we have a lesion which, just take note how similar it looks to the uterine fibroids. So a very typical just gestalt kind of feeling for a fibroma, and I'm just going to take it all, because it's quite an obvious appearance. I'm not going to do too much guesswork with this case. Fibromas look like fibroids. Okay, fibromas are typically small, well-circumscribed masses with acoustic shadowing, and when we see a neck cell mass which is small, solid, and it has acoustic shadowing, and it's regular, and it's got no internal vascularity, we are very glad, because we can be quite reassuring. We still would send this patient to a gynecologist generally for review. They will still need monitoring, and certainly if the lesion grows on monitoring, it would need to come out. But a lot of the time these tumours can be observed and spare the patients surgery through lack of definitive diagnosis or definitive opinion. According to iota simple rules, both the shadowing and absence of vascularity are benign features. It has no M features. The adnex model, 60-year-old patient with a solid mass and none of these other things, and acoustic shadows present, 97% chance of benign tumour, despite patient being in a postmenopausal group. So you can see how much they really value, I think, this acoustic shadowing thing. It was also small. And ORAD's also low risk of malignancy, 1 to 10%, management by gynecologists, which is what we'd already discussed from our clinical opinion as well. So a diagnosis of probable fibroma, probable because this tumour was never excised, and it was followed up and it was stable. Okay, next case, we haven't got any clinical information given, but this is a premenopausal patient. Right adnexal mass. So this lesion is predominantly solid. It's got a few cystic components to it, but not a lot. So it's certainly less than 80%. So we call this a solid mass. Just trying to find some color pictures. They're mostly on the transabdominal, I think, images. So there is some color. It's not color score 4, so it's not extremely colorful. Not what I want to say. It's not that marked vascularity, but nonetheless a solid mass in the adnexa. Not much else to say. We're certainly concerned. We want to. We think that this is likely to be malignant. Iota simple rules, 1 M feature, irregular solid tumour. So Iota agrees it's a malignant lesion. Adnex score, so 79 millimeter lesion, which is essentially solid, no locules, no papillary projections, no acoustic shadows, no ascites, gives it a 40% chance of malignancy, but note that not borderline. If it's malignant, it's potentially high grade. 40% is certainly, whilst you could say, well, it's saying more than 50% chance of benign tumour, but nonetheless our cutoff will be somewhere between 10 and 20% for surgical excision. So still very much within that zone where we would recommend surgery. And ORADs, category 5, high risk of malignancy, management by a gynae oncologist. So that's a typo, and there's 2 typos there. That should both have been changed. So management by gynae oncologist, category 5 lesion. And this was a granulosa cell tumour, right? So we're within that sex called stromal area. Not too much particular about this tumour. There is, again, just as we were talking about with a couple of the other tumour types, when are there these little things that we can latch onto that hedge us towards one way or another? I mean, firstly, I hope I've made it fairly clear that the specific histological subtype is less important at this stage than making the assessment of, is this malignant and needing to come out, or can this be watched, or is this likely to resolve on its own? So in this setting, Nothing in this case too particular, but just again out of interest, there is sort of this feature of granulosa cell tumours being called having Swiss cheese, so that the typical granulosa cell tumour appearance is a solid mass with lots and lots of cystic spaces throughout. Not that you'd make a call on that, and you know that once I start putting pictures of cheese on my slides, I'm desperately trying to hold on to attention of whoever's left with me. And with that, I'm moving on to the last case. So this was also a premenopausal patient. I believe she was 40 years old. And first couple of images here, uterus with lots of fluid around it and a very irregular mass with lots of cystic spaces. I mean, just on the first picture, this is badness, right? There's something bad going on here. We've got ascites and we've got a big angry looking tumour here. So again, lots of ascites. So this is either, depending on how you want to call it, this is either a solid tumour, this is a multilocular solid tumour. It doesn't really matter. It looks terrible. It's very, very vascular. It's got ascites. And in fact, we do have the CT available as well. There's a few potentially liver lesions which we can't quite characterize on this scan alone. You can see the ascites. She's also got bilateral pleural effusions. Just checking, she's got some prominent lymph nodes as well, lymphadenopathy. So it's lots and lots of concerning features, and also just coming through. So there's just to give you a better idea of the size of the mass. And probably just coming back to this series as well. Subtle amongst everything else going on, but here's actually a segment of sigmoid colon which has got generalized mural thickening. So we're concerned, full stop, and we're also concerned that this may be secondary. IOTA simple rules gives us 3M features. IOTA adnex model gives us 96% chance of malignancy. With higher grade tumour, either higher grade tumour or metastasis favoured. And ORAS is also in agreement, and this was metastasis to ovary from the gastrointestinal tract, from bowel. So I think these cases show that we've got fairly good correlation in most cases. And I think it's somewhat reassuring that the risk stratification models are generally in agreement with what we would have thought anyway. And often it's helpful to use one of these, I think, as I tend to make up my mind first and then turn to something to help me just for reassurance, or perhaps to reconsider if it doesn't agree with me. So in summary, I really suggest and advise the use of standardized and discriminatory terminology. It helps people understand what you're reporting, and it helps you apply your reports to stratification models if you wish to use them in conjunction with your reporting. Do try and indicate your risk and your opinion where possible, and do try and suggest sensible management and follow-up where possible. And thank you for listening.